Okay, so this is the home health / hospice in-service for emergency preparedness, infection control, and QAPI. We all have heard and know that the conditions of participation for home health are drastically changing in 2018. Don't think a whole lot in hospice is changing other than your guys' now reportable outcomes that you're getting on your compares. So some of this will play in line with that, some of it may not. But as a recap of what home health is looking at, CMS implemented new conditions that require all agencies to implement an emergency disaster preparedness plan to be activated in the event of a disaster. This has come forth based off of all of the natural disasters we've seen around the U.S. recently, the hurricanes down in the south, and seeing the impact that that had on patient care not being delivered timely, and what we need to do to prepare for those types of events in this area, and basically having a plan in place so that we're not all running around with our heads cut off trying to figure out how we're going to get to patients, communicate with patients, and get them the services that they need. They also added to that requirement a complete infection control program. Most agencies already have infection control policies in place, and everybody practices infection control with standard precautions. What CMS requires of home health now is a true surveillance program, investigation program into prevention and preventing the spread of disease. So it's now a requirement for an in-depth, true infection control program. And then the quality assessment and performance improvement QAPI program really expanded. We've always done outcome improvement and action plans of how we can improve patient care. CMS is now requiring that to be very, very comprehensive, agency-wide, looking at a variety of outcomes and actually putting plans into place and showing monitoring activities to really see progress within the agencies. So the Emergency Disaster Preparedness Program consists of 4 different parts to the program. The actual plan, what we will do, the policies and procedures for the agency that go along with it, a communications plan, which will detail out how you will communicate with patients, emergency responders, how we'll communicate interagency if communications are down, and then a training and testing program. Training is what we are doing now. We're doing training with staff. Testing is actually testing that plan itself. So there's requirements that we do mock tests to see how our plan works. So part of the program is the Emergency Disaster Preparedness Plan. These are the steps that were involved in developing that plan. So it wasn't as easy as just here's some of the things we could see. We actually had to do a agency-wide hazard vulnerability assessment. That had to include what they call an all hazards approach. So we had to look at man-made disasters. We had to look at natural disasters, technology, everything that could possibly impact the agency. Then we had to look at our mitigation tactics. What can we do to mitigate or lessen the impact of this emergency? What we are doing to prepare for it, how we would activate it, and then how we would recover. So these are all different areas you'll see within the Emergency Disaster Preparedness Plan that directs basically all agency staff on what their role is, from the field staff all the way up to the administrative staff, what everybody's role is if this plan were to be activated. So first thing was the hazard vulnerability assessment. Like I said, it uses an all hazards approach for natural events, man-made incidents, technological disruptions, and communicable diseases, as well as anything else we were to find. I've listed here some hazards. These are the hazards we found in the Springfield area. Basically, when doing this, we had to go in and look at all of the county records for what type of emergencies have occurred in this area over the past 5 years. Luckily, most counties and cities do their own vulnerability assessments, so there was quite a bit of data out there to work with. But when we look at this, we think about all of the territories and all of the counties that are served out of this branch location. For us, the only county we had to worry about was the actual county that the office is located in. So these hazards may not match up with Stone County or Taney County down the road. It just has to apply to where your agency is located. So when you're looking over your plans, and once you guys get a copy of your plans, you'll want to make sure and look at the specific hazards that have been identified in the area that you're servicing. So in this area, obviously winter storms, extreme heat and cold, floods, hail, things we don't think about as much as cyber attacks and hazardous material spills. We all have to start thinking in terms of workplace violence, civil disorder, terrorism. One thing that this Springfield area has is plane crashes. Why we have a lot of plane crashes, I'm not for sure, but in this area we do. We all have to prepare for power failure. That would be something that every agency would risk. Cyber disruption, animal disease, and by that it's going more into mosquito bites and tick bites. Communicable diseases like the flu. And then in this area, we see a lot of sinkholes. So sinkholes was one of our hazards that we identified. So like I said, when you get your plan, make sure to look at all of the hazards that are in your area. If you're in the Springfield area, then these will be the hazards identified on your plan. All right, so hazard mitigation. That refers to the actions taken to reduce the impact of the emergency or the disaster. It lessens the impact. So things that we look at here are how can we prevent these things from occurring? How can we protect property? What education does the public need in order to help them prepare for it? Natural resource protection. What are we doing to protect our natural resources that are here now? Emergency services as far as cooperation and coordination, and then structural projects. That's not something we necessarily do, but building codes and things like that have to now change based off of the hazards in the area. So just like, if you lived in a hurricane prone area, the building codes there are going to be a lot different than here, where we don't have necessarily in this area tornado protocols that are required, but a lot of builders are building better to code to withstand F5 tornadoes. So for our plan, we are going to implement infection control surveillance, equipment and supply management, individualized patient emergency plans, utilizing volunteers and community coordination, and then evacuation plans. So with infection control surveillance, basically what we are looking at there is that we have to monitor the public a little bit more and report what we are seeing as far as what kind of signs and symptoms we're seeing in the public. So employees are expected to report all patient infections and antibiotic use. If patients come on service, a lot of times they come to us already with an active infection and on antibiotics. And that's okay, but we still want to report it, because when we go back and investigate that, we want to be able to track it that they came on service with this infection and it's not an agency-acquired infection, something that we brought on. So it is important to even report those infections when patients are admitted. Employees are expected to notify their administrator if they're ill or taking antibiotics. This goes back to trying to trace the source of infection. So if we have an employee that was sick 2 days prior to a patient getting sick, we want to be able to track that back. There is no punitive or punishment or disciplinary action associated with this. This is truly just a way for us to track how infections are occurring. So very important that your administrator know, and they will be keeping an employee infection log of any employees that are sick. And like I said, that just comes back to us being able to track back patient infections. And finally, that employees are expected to follow standard precautions and utilizing appropriate PPE. So you're wearing gloves with any contact with blood or body fluids. You're washing your hands. You're using proper aseptic technique with any sterile procedures that you're doing. We'll get a little bit more into infection control when we talk about that actual program, but infection control is inherent to the emergency preparedness plan as well. Equipment and supply management. The expectation is that employees will ensure that all of their patients have at least a week's worth of supplies specific to them in their homes at all times, so that if our supply storage was wiped out, they would have at least a week's worth in their home as far as wound care supplies, catheters, any ventilator, equipment, trach cleaning equipment, anything that's specific to that patient. They should have at least a week's worth of supply stocked in their home at all times. What that means is that each time that patient is visited by anybody, those supplies are checked. And if they need to be restocked, that's communicated with the next person going out so that we can ensure that stock is always there. The agency is also preparing emergency preparedness kits that are going to be kept in the storeroom or your supply room for emergent use. The expectation is we'll have at least 3 bags full of, we have designated equipment and supplies that will be kept in those bags. Things, gauze, wound care supplies, catheter supplies, ostomy supplies, anything that you guys use on a regular basis should be kept in an emergency preparedness kit. You need to make sure that whoever is responsible for ordering your supplies gets enough stock in to stock those bags. It is the responsibility of the agency and the administrator to make sure that the dates are checked on those every month so that we can make sure we're not keeping expired supplies within those kits. So there is going to be a log to track that those bags are checked at least monthly. Finally, employees should keep car stock in case of an emergency. We also have a list for that as far as what is the recommended bare minimum that employees should keep in their cars. I don't think that, it is part of the handouts. So car stock includes not only just the supplies, but a map of the area, contact numbers for resources in your area as far as other agencies, DME suppliers, people that you would need to be able to get in touch with, flashlights, batteries, gloves, masks, and then the things that we talked about as far as catheters and gauze and tape and bandages. It also has winter storm supplies. Should always be stocked in your car during the winter season. So make sure and review the car stock that is expected, and that you guys will be expected to make sure and you're checking the expiration dates and things of your car stock. That again will be reported to the administrator monthly. So there'll be a checklist for employee car stock that you guys have checked your expiration dates and replenished anything that needs to be replenished out of your car stock. So individualized patient emergency plans. This is one area where home health and hospice may differ quite a bit. The emergency triage levels here are listed straight out of the Access software to align with that platform. So this will probably be different for the hospice agency as far as what your triage levels are. But basically, you need to be able to associate your patient with a triage level. It should be based on their diagnosis, their care or their treatment plan, support systems in place, special equipment needs, and safety needs. So what we're looking at in this is kind of twofold. If a patient has, a daily wound care that has to be done, they live with nobody else. Nobody can do that daily wound care. They depend on the agency to provide that service. Then they have to resume services in case of an emergency. There's no other choice. So they would be considered a level 1, even though that says it's life-threatening. They cannot have their services interrupted. They are completely dependent upon us. The other thing that comes into this play is the evacuation needs of that patient. If they live alone, are wheelchair-bound, paraplegic, don't have a caregiver that's routinely in the home, they cannot evacuate by themselves. They require assistance. That means they're a level 1 patient as well. So there's multiple levels to this. And what I've been telling people is, if you're stuck between a level 1 and a level 2, always go to the level 1, because we want to make sure we get them the care that they need in a timely manner. A level 2 patient in the Access world means it's not life-threatening. They're not dependent on the agency to get out there that same day, but they do have needs that must be met by the agency. Level 3, visits could be postponed 24 to 48 hours. And level 4, they could be postponed 72 to 96 hours. Now, CMS is pretty adamant that anything more than 96 hours as far as a delay in service, we should start considering transferring patients to alternate facilities. They say that if you cannot get to your patients within 96 hours, that is detrimental to the safety of the patient. So if we are in an event where we think we're going to go, a week without being able to see patients, we need to start immediately making preparations for them as far as emergency responders getting out there to transfer them to a hospital, to a skilled nursing facility, wherever we can find placement for them that they can get the care that they need. Otherwise, we triage these patients during an emergency based off of their triage levels. So level 1 patients, like we said, they have to resume care. We have to find a way to get somebody out there to see those patients. Level 2 patients definitely need to be considered. Within that day, you may, push it to the next day, but within the first 48 hours, they should be seeing somebody there. Level 3 and level 4 patients are more going to be phone call triage. The expectation is those patients wouldn't require a visit during that 96 hours. We can push those visits and they would be safe to do that. So for these patients, you're looking at, your education patients, the patients that are not dependent on the agency for some type of, skill. They're more the patients that you're treating for education and chronic disease management. So make sure and look through once you get your plan. Make sure and look at all of the details as far as your triage levels, because this is truly going to be the foundation for how visits are determined in the event of an emergency. Your administrator is going to assign visits based off of these triage levels, and she's going to push visits based off of these triage levels. Excuse me. So, employees at the time of admission, when you go out to admit a new patient, you'll request that that patient provide the agency with an emergency contact. Now, we always do that, and they usually give us that one person that we should contact in case of an emergency. But CMS is saying we need to go beyond that. Not only do we need to have emergency contacts, we also need to have an address of where they would evacuate. So if that patient knows, if I had to leave my home, I would go stay with my daughter in Alabama. We need to make sure and put that address down so that if we had to call emergency responders to pick that patient up, we would need to be trying to find arrangements for them to get to their daughter in Alabama. The other thing they're saying is the concept of emergency contacts needs to be expanded. Not just that one person, that daughter that lives in Alabama. Does that patient have a neighbor that helps them out routinely, gets their mail for them every day? So that if we could not make contact with that patient, that neighbor could easily go over and check on their status and report back to us. Do they have, a nearby relative that transports them to doctor's appointments? We want to include in the emergency contacts anybody that could provide us with information on that patient during a time of an emergency if we could not make contact with them. We definitely still want that daughter in Alabama because that's who we're basically going to have to try to get that patient to, but we also want people in that vicinity that could check on that patient in time of a disaster. Employees will assess for any additional assistance required during an emergency. So things like if that patient is oxygen dependent, we need to be able to tell emergency responders they have to have their oxygen to leave the home. If they're bedbound, we need to be able to tell emergency responders you're going to have a gurney of some sort to evacuate that patient. Anything that they would need to safely evacuate their home, we need to identify within their chart so that it's easy for us to get in and say they require a walker to get out of their home. They require oxygen. They're ventilator dependent. So, they're going to require some sort of battery backup to supply power to their ventilator. So any medical equipment or any needs to allow them to evacuate and remain safely in their home. So those are the patients that you also ask, if you are oxygen dependent, do you have backup tanks? You know, how many tanks do you keep on hand so that we know how much time they have for backup oxygen? You know, the ventilator patient, what is their battery backup? Do they have generators? Do they not? Is that a patient that we need to expect they don't have any type of battery backup? They need 911 called immediately in case of a power outage. So what are their needs and what are their equipment to stay in their home and to evacuate safely? Patients also will be provided 2 handouts. One of them is the family communication plan, which basically allows them to go through and identify those emergency contacts, write down their insurance information, write down any other significant information that would need to be passed on to receiving facilities or EMS responders that were to come and pick them up, some type of communication plan so that they can pass that on and people know who to contact and what to do for them. The second thing is an emergency supply list. This is basically giving that patient, if you're going to compile an emergency kit for yourself here in your home, these are the things that FEMA recommends that you gather and put in one place, whether it's a tote, whether it's a bag, and it includes a variety of things, kind of like our car stock. It includes, 3 days worth of medication. It includes water. It includes flashlights and batteries and anything specific to them. But both of these documents are put out by FEMA in trying to get the community to prepare for these types of an emergency. So both of those will be delivered to your patients and should be part of your admission packets. It's not something that's required, so we can't force them to fill this out, but it's something that we should encourage and recommend as, the push is to get the community involved and get the community preparedness as well as our agency. All right, our personal evacuation plan. So each location has to develop an evacuation plan if we were to need to get out of this building immediately. So every agency has to establish a meeting location in the event the building is evacuated. Here in the Springfield office, our evacuation area is the flagpole in front of the main office. So if there were a fire, we would be expected to meet there and everybody get accounted for, okay? The administrator is responsible for accounting for the presence of every staff member if the building is evacuated. Now, that's a big responsibility, especially as staff members come and go, and you don't always know exactly who's here in the office. But that puts a little bit more on that administrator to be aware of the surroundings and who's in the office so that they can account for them in case of an evacuation. Well, guess I'm talking too slow. Hello. All right, guys. Hold on. My computer decides it wants to do something funky. Okay, so developing your evacuation plan is imperative so that your staff know where to go to meet in case of an emergency. Sorry, guys, I'm waiting for this to come back up. Of course, something has to go wrong. It's on my computer. It's not feeding into yours. Hey, Suzanne, can you guys still see my screen? Strange. Okay. It's just not letting us see it. Okay. Goodness gracious. Okay. Back to where we were. Very weird. So every agency has to have their evacuation plan in place so that your staff know where to go. It is very important that you do not leave the area without the approval of your administrator. Because as we said, she's trying to get an accounting for everybody. So make sure if something's going on, you don't just jump in your car and go. So make sure you check with them and get the approval before you leave. Each agency will also have to establish an alternate off-site command station where staff would meet or come together if the office was inoperable. So make sure you look within your evacuation plan and know where that location is. For hospice,
oh yeah, I mean we have Tara down, but we could.
You do have Tara, do?
Yeah.
Okay, that's who home health has. So Tara is the lucky lady that gets to wine and dine us during the event of an inoperable.
And we can also go to my house for like 5 minutes.
So just make sure there's an off-site area so that if this building was gone, obviously we have to have some place to call headquarters. So that will be established within your evacuation plan of your emergency preparedness plan. Okay, so when we talk about being prepared, so what is the agency required to do to be prepared for this emergency? A lot of it is having resources, having contact lists. The administrator is responsible for having an updated employee list at all times, a patient list with triage levels like we discussed, entities that provide services for us. So our medical suppliers, the companies we use primarily for oxygen. Where do we get our medical supplies from? What DME companies do we use? Including what other home health agencies are in this area. If we had to push some patients for overflow, who could we seek to assist us? What are the nursing facilities in the area, the acute care hospitals, the rehab units? Who could we count on or who could we request help us to take care of these patients? Any volunteers that are on staff? And then we also have to have the contact numbers of the federal, state, and local law enforcement. So Greene County has an emergency management office. That's who we would resource out of. So each location and each agency has to know what their emergency management office is and what they encompass. And then any other source of assistance that we would expect could be utilized in case of a disaster. We have to have hard copies of that. So your administrator is responsible for, at her place of residence, keeping copies of the employee list, of the contact list. Those are things that you guys could keep optionally, but the one thing you guys are expected to keep on hand is your staff notification tree. And we're going to talk about that here in just a second. Your organizational chart has to be kept on hand. So your administrator has to know who she reports to. You guys need to know who you report to. In the home health arena, there's case managers, there's assistant directors of nursing, there's a director of nursing, there's your administrator. So you need to make sure that your branch has a organizational chart that shows where your next reporting step would be. Communication devices is another way we prepare. How are we going to communicate with each other? And then our testing, training, and evaluation. So we went over some of those contact lists, but here's your staff notification tree. So basically what this is if your plan were activated, if your administrator at any point decides to activate your emergency disaster preparedness plan, she will initiate the staff notification tree, which is a way to get this information out to all of the agency staff within an hour. Okay, the goal is that all staff are contacted within the first hour. So there will be a tree of your name, your credential, and your phone numbers. And basically you go down the list. So Melanie contacts Jill. Jill contacts the next person. The next person contacts the next person. So you go down this tree, basically relaying the information. You know, Melanie's activated the emergency preparedness plan. She wants us to stay in our homes, and she'll contact us with further information. Or it could be, you know, the agency was swept away by a tornado. We're operating out of, you know, Tara's house. We've been asked to everybody meet there so that we can get a game plan together. So you will get instructions on what you should do through that staff notification tree. If at any time you cannot contact the person that is below you, you will contact your administrator and let them know, I've tried 3 times, I can't make contact, because we don't want you spending an hour trying to find that person. We want you to move on. So let your administrator know. She will take that person over and try to find them. You'll move down to the next person on the list. Okay. One thing specific for home health as far as these contact lists is the case managers, and this may be the same in hospice. If it is, then perfect. But case managers are expected to maintain a current list of the patients that they are responsible for at all times. So when we talked about the triage levels, we talked about level 1 and level 2 patients are probably going to have to be seen. Level 3 and level 4 are going to be phone calls. Well, it's going to be up to the case managers to make those phone calls. So you need to be able to have a contact list for the patients you're responsible for, so that when that tree is activated, you know which patients you have to contact. Okay. So continuity of operations, what that means is we want to make sure we're still operable. So if the agency is no longer here and we're operating out of our alternate site, we need to make sure that there's a computer there. We need to make sure that there's, you know, a phone system that's working there, because we have to now make that the hub of our operations. That also means that the administrator and any support staff that are deemed required will make every effort to get there. So, you know, worst case scenario, say, you know, Melanie, you know, okay, let's say Jean. Jean lives out in Buffalo. If she's not able to make it into the office, then she'll operate out of her home. But she is expected to make every effort possible to get in as the administrator to run operations. Same with your required support staff. In the home health office, their scheduler is essential. So she's part of that required support staff to make every effort. Now, obviously, we're not going to expect you to walk in from Buffalo to get here. So worst case scenario, you need to make sure that your home is operational, you know, to work out of there. So you have a tablet, you have, you know, whatever you need to work out of your home. But the expectation is that primary staff will make every effort to get in to run the office. How do we follow up with staff and patients? So we already talked about the staff notification tree. That's your guys' contact. That's a way for your administrator to know everybody on staff is safe and secure in their homes, or we can't contact this one person. They were in the middle of this disaster. Her responsibility now becomes to get that information to the emergency management office for the county so that they know we need to check on this person. Scheduling of level 1 and level 2 patients will occur from your administrator. So your administrator will use those triage levels like we talked about to decide, okay, you know, Jane Smith, daily wound care, she's a level 1, she has to be seen. John Doe is a level 2, he doesn't have a need this very minute, we will get out to see him tomorrow. So she'll make that determination, but she has to have those accurate triage levels. Otherwise, if somebody's really a 1 and you've got them listed in a 4, she's not even looking at them for a visit, okay? So those triage levels are critical when it comes to arranging the visits of patients during an emergency. Level 3 and level 4 patients will all be phone calls. So that'll be done by the case managers, or if you have an assistant director of nursing, she will assist with that. Basically, those calls are just to establish their safety, their whereabouts, Do they have food? Do they have water? Do they have a roof? What is the condition of that patient? Again, if you receive information from a patient at that point that says, my roof's been blown off, there's water coming into my house, they're not safe to be there. So that's when you then initiate that transfer of that patient. Now, the expectation for home health, we're not going out to help evacuate all of these people. We are relaying this information to emergency responders. The key to this whole plan is that coordination with our community and with emergency responders. But this is where that contact is made, determinations are made as far as if they're safe to remain in their home. They're noted as a level 3 or level 4. They've got food, they've got water, their daughter is there with them. They're tucked in for the next 96 hours if they need to be. So we can move on. Everything and every contact you make with patients has to be recorded. Hopefully, you guys can all get into your electronic medical records. If not, then you go back to paper and pen, but you make sure that you're documenting everything, because once this is over, it's CMS. We have to have documentation for everything we do. So we'll have to get all of that uploaded into patients' charts. So the response. So the plan is activated. So there is a F3 tornado that hit this location. Melanie is the one that makes the determination whether to activate this plan. Now, just because there's a tornado, it's out in Buffalo, doesn't mean the plan's activated. This plan has to do with the agency operations. Is the agency capable of continuing to operate normally? If the answer is yes, then there's no reason to activate our emergency plan. If the answer is no, that's when we have needs. We have to prioritize. And it may be the office is perfectly, okay, we have power, this office is running great, but say half of the staff lives out in Buffalo, and that's where the impact was. So now your administrator is looking at, you're down half staff because those staff can't get in. That may be an indication to activate the plan because you can't see everybody, so you have to triage those patients out. So there's a lot of indications for activating this plan, and that's why your administrator has to have those broad shoulders to make those determinations. Okay, so communication and coordination. Your administrator will contact the emergency management office. She will let them know any unaccounted for staff and or patients. So we say staff should be contacted within an hour's time. That should initiate then the next step in your plan, which is scheduling out visits and those case managers making calls to patients. As you are making calls, when you cannot make contact, you need to make sure your administrator knows, because she's going to be keeping a list of unaccounted for staff and patients. When you call those patients, you assess their need to evacuate. Are they safe in their homes? Do they have the supplies, the equipment, the resources available to maintain where they're at? If the answer is no, you need to be letting your administrator know that too, because she has to be the hub of making sure, okay, this patient's going to this facility, this patient we're asking to go to this facility. She's going to be that one with the big book of where's everybody going and when. She will be the coordinator for your patient transfers. Now, it doesn't mean that she's going to call each facility and make arrangements, but she also knows she can't send 15 patients to one facility. They've got to be dished out. We've got to have some resources. So she's the one that's going to decide, okay, this facility, I've talked to them, they can take on 5, this one can take 2, and kind of determining where patients go. Documentation, like we talked about, key communication notes for all contact made with patients, tracking logs, which is the responsibility of your administrator for staff locations and patient visits. One of the things with patient visits is we're sending staff out into possibly unsafe, areas. We don't know what's out there, so the expectation is if you're assigned a visit that you are communicating constantly back with whether it's your administrator or somebody she designates to say, okay, I'm leaving, to patient A. I'm at patient A, I'm leaving patient A, I'm moving on to patient B. That way, if we at some point cannot make contact with you, we're able to say she was between patient A and patient B. That's where we send resources. Okay. Now, it's not to say that we're going to send you into the midst of, a F5, type condition, but we may not always know. We're sending you to patient A because they're a level 1 patient. We may not know what the conditions are. So that communication is essential to, I'm safely here, I'm safely traveling.
There's a tree down in the middle of the road.
Exactly. I'm walking, the 2 blocks to try to get to this patient's house. We are responsible for ensuring your safety while you're out there seeing patients too. So that communication is essential. We will have emergency documentation packets. So we will prepare for the fact that your electronic medical record is down. So there will be skilled nurse notes. There will be paper communication notes. There will be paper physician orders. Admissions will be done a lot differently in the midst of an emergency. We can't expect, or we don't want, staff spending 3 hours in one patient's home getting them admitted. If somebody has to be admitted during that time, it's probably because the hospitals or the facilities are pushing out to make room for critically injured. So we want to still be able to take those patients. We have to be able to expect that surge, but we also can't dedicate 3 hours for one patient. So the admission process will be skimmied down. It will be, what does this patient need to make it through the next 96 hours so that we can get back to normal operations. That includes, you're not going to take the time to sit there and write out a medication list. Hopefully you have something that facility has sent us. Okay, check. They're taking all these meds. And then the expectation is once this disaster time is over, we can fill in the blanks. But it's going to be skimmy down. The expectation of being able to contact physicians to get those specific orders can't be there. In home health, we can get an order from Dr. J, who is working in the acute care hospital, but the patient is actually going to be following up with Dr. D. Normally, in home health, we wouldn't admit the patient unless we could get an order from Dr. D to say he's going to follow. In these situations, as long as it's a physician's order, we'll take those patients and we'll keep moving. We'll worry about the technicalities once we get the patient safe at home and get them what they need. So there will be a lot of, shortcuts. The visits are not going to be the same. You're not going to go out there for education. We're going out there for those skills that require us to be there, and that's about it. So it may be a 10-minute visit to go in and change that dressing, and then you're out. So expect that everything operates a little bit differently. Read through your plan to kind of get a better idea of what that admission process is, what the requirements are, what we're waiving. There's details within the policies that we've created to go through the steps to that process. So then how do we recover from this? We could be talking a couple days, weeks. Some disasters take months to actually recover. That's where, the agency has to make that determination. Are we able to resume normal activities within 96 hours? The answer is no. Then we have to start considering transferring our patients until we can say we can resume normal activities. Those are conversations that'll be happening between your administrator and the VPs and Phil, determining, how we proceed. But if we can't care for the patients, we can't operate normally. So just know that, depending on the type of disaster, the impact, the damage, you could be talking a long time for recovery for some of this. It's important for staff members to make sure your administrator knows what your abilities are once normal activities do resume. So, there was that tornado that took out, this part of the town. We're back to normal operations in the office, but your house was impacted. You still have to get your household in order. So it's important that you communicate, I need a few more days to get this wrapped up, because your administrator has to then say, how many staff members do I have? Am I at a point I can resume normal activity? So it's important to keep that communication and to be honest about it. I mean, during disasters, the emotional toll that can take on staff can be harsh as well. So your emotional ability to return to normal operations is something to discuss. So your administrator's looking at staff availability, how to reassign caseloads. You may have admitted 50 patients in a matter of 2 days. Well, how do we redistribute those? How do we reassign those caseloads? How do those case managers get report? It's very important at this point that verbal report is giving, that these case managers don't just take on a piece of paper and be expected to know what's going on. It's very important for anybody that's been out to see patients, give a verbal report to those case managers. This case manager may not have seen the patient here. You guys need to make sure and communicate back to them what you've seen. Uploading of documents. So all of those paper documents, if you have them, have to be uploaded into the patient's chart. With regards to the home health oasis, there are waivers that we can do, or we can request from CMS to waive an oasis requirement during the time of disaster. It's a process of submitting, everything, but that is a possibility. Doesn't mean it'll be approved, but it is a possibility. And then your administrator filing all those tracking logs. We have to put all of that into a binder, say this was a plan activation, and it then serves as a learning tool. What went good, what went wrong. And CMS is so nice to say that if we have a disaster and we have to activate our plan, we don't have to test it for a year. So, how lucky. That's very sweet. Okay. So the program we talked about, we've reviewed the plan. These are the policies and procedures that have been developed to coincide with this plan. So your true hazard vulnerability assessment. So that's going to allow you to see every hazard identified in your area. One thing that's important for everybody to look through is the hazard protocol. So basically this is just safety tips and what the expectation is during each hazard. So it gives information on what to do for a fire, what to do for a tornado. It's basically safety 101 for each of the hazards that we've identified. Emergency triage levels. Again, we've gone round and round that is key to operations. So make sure you read the policy on your emergency triage levels so that you have a clear understanding of what those are, so that we can ensure you assign them correctly. Your individualized patient emergency plan, that basically is going through what the expectation is that you're reviewing with your patients. We have included new information that will be given to patients regarding emergency preparedness. I don't know if I have it with me or not, but it basically is going to give some basics, fire safety, what to do in case of a tornado, things like that. So the most common ones we're including in part of that admit pack or that patient handbook. Reprioritization and response to emergency events. Basically, that is the policy that allows the agency to say, okay, we're not going to see level 3 and level 4 patients, we're going to see level 1 and level 2. So it basically shows how those are assigned by your administrator. The patient admission and assessments is going to go over the things we talked about as far as the revisions, the not so robust admissions. So it's going to tell you what's the expectation for admissions and assessments, and then also transfers and discharge. Obviously, we don't just decide, okay, let's discharge A, B, C, and D. We have to make contact with those patients. We have to make sure they're in agreement. But there are some patients that possibly may have to be discharged early in order to accommodate the influx of new patients you're getting. So there are policies for that. Our communication plan basically says that landline phones, or here in the office we have the voice over internet phones, is our main line of communication. Cellular phones is our next. Text messages, And then each office, each agency should have a two-way radio. This is our last resort. Cellular lines are down, landlines are down. Your administrator will keep a two-way radio to be able to make contact with the emergency management office. Okay?
One two-way radio.
One two-way radio. Now, what does that mean for everybody in communicating interagency? We're dead in the water at that point. That means doing the best we can and keeping our fingers crossed that everything comes up. One thing I can say is even with cellular networks down, text messages a lot of times still work. So that's kind of our go-to for communication if the landlines are down and you don't have a cellular communication. Other thing is, the internet. So a lot of times internet will still be operational even though you don't have phones. So utilizing your internet as a contact. I mean, you hear all the time about people posting things on Facebook in the middle of, a hurricane. So somehow they are still getting reception. So utilizing all of those aspects, that's part of our communication plan. Testing and training of the program. There is a self-study module that everybody will get. We're required annually to do this self-study module and take an exam. Basically, CMS says that we have to prove that everybody's been in service, everybody has an understanding of their role, everybody has access to all of the information. So there will be a final exam administered, and then you'll do that annually. The module will be updated annually as well if things change. So the testing, like we talked about, we're required to do a full-scale exercise plus an additional either full-scale or tabletop exercise. So I can tell you for us, it's almost always going to be one annual full-scale and one tabletop. Full-scale is just like we talked about. We pretend and we act out that we're activating our plan. Now, does that mean I'm sending to Buffalo to check on that tree? No. But we are activating our staff notification tree. We are, say part of our scenario is the internet is down. How is everybody gathering their documents? How is everybody charting? So it may be, an hour that you guys go out and you chart on paper for a little bit to see how it goes. But we have to actually act it out. CMS likes us to do this in a community environment. So we've reached out here in Springfield to the emergency management office. We've reached out to the local hospitals. Nobody's doing any live exercises. This is such a new requirement that nobody's looked at that. But I did speak with Greene County, and their plan is by next year to have some sort of community involvement with home health agencies. So hopefully by next year, we'll be able to get in on their full-scale exercise. In addition is a tabletop, which is just basically another scenario, and we kind of talk it through. Well, what if this happened? Well, what if that happened? Are we prepared for it? It is the expectation that all staff participate in both. The tabletop isn't as critical as the full scale, as long as at the tabletop we have a variety of agency staff from all disciplines that participate that can bring up different scenarios. So be waiting for Melanie's word on when we are going to be doing this. Okay, so that's our emergency preparedness, and we kind of talked about the infection control program is inherent to that as far as surveillance. But here is where, kind of like I said, CMS has gone a step further. It's not just about control. It's not just about standard precautions. They expect control, prevention, and education. So part of our infection control is the surveillance. It's reporting and identifying, analysis and investigation, and controlling the spread. So when we talk about surveillance and reporting, make sure that when you guys are going out to see patients that you're putting in their charts their current vaccinations. CMS is really big on flu, pneumonia, and shingles. Why those are their three of choice, but they are. So if your patient has had those vaccinations, make sure that we record that in the patient's chart. In hospice, we're not going to then expect anybody to go out and get their flu shot. But in home health, that is the expectation. The expectation in home health is that you make arrangements, make appointments, get that patient in to get these 3 vaccines. Employees must report, like we talked about, infections for any patient. So that includes every type of infection: gastrointestinal, respiratory, wound or skin, urinary tract infections. All of those we're being expected to track and trend. In home health, employees must report flu-like symptoms to the physicians. Doesn't really apply so much in hospice. Your physicians aren't going to treat the flu usually for your patients. In home health, it's a requirement. It's a requirement that if we see flu-like symptoms, that we are notifying that patient's physician to try to get them in and get them treatment. Employees must report self-report their illnesses or infections. You must report all sharps injuries. That's part of infection control, is controlling our sharps injuries. And then you must also report any occupational exposure to blood or body fluid. Now, what OSHA says as far as occupational exposure doesn't mean that you touched some body fluid with intact skin, okay? If you have contact with somebody else's blood or body fluid to your mucous membranes or to your open skin lesion of any type, you need to be reporting it. So that's what they consider: mucous membrane or open or damaged skin. To control the spread of infections, we recommend that employees screen their patients for the flu prior to their visits during flu season. What that means is between the months of October and March, you're calling to arrange your routine visits with your patients. You simply ask them, how have you been feeling? Have you had any, coughing, fevers, that sort of thing? If they have, we would prefer that staff go out and see patients during that active time. We want to make sure the patient's safe. We want to make sure that they have notified their physician, that they're on medication, whatever it may be. But if that visit by you isn't imminent on that day, we would rather see it rescheduled until a time where they're not so active with the flu-like symptoms. So just screening those patients and trying to avoid putting yourself or somebody else in the home of a contagious flu patient. Employees will adhere to standard precautions, okay? We have revised our policy on what standard precautions means. So there is a handout that everybody should get on hand hygiene, on the use of PPE, proper handling and cleaning of equipment, safe injection practices, proper handling and disposal of needles, and then proper disposal of other infectious waste. So everybody should at least get this, because this should not change. One thing that I can say that led us to this is the CDC has put out a statement that now says alcohol-based hand sanitizers are most effective for reducing germs. And if your hands are not visibly soiled, it's preferred that you use alcohol-based hand sanitizer versus soap and water. Very big change for most of us to think about. But that is what they're coming out with, that it is the safer way and it is better to use the hand sanitizer versus soap and water if your hands are not visibly dirty. So review those. It's got the steps. Everybody knows we have to have the procedure for washing your hands. It's got the steps for hand hygiene. It goes through the PPE that's available as far as gloves, gowns, things along those lines. Bag technique. Don't think it's changed a lot, but I know the current policy we have is like a full page on bag techniques, so we've kind of drummed it down a little bit. Medical supplies and cleaning is something that we expect CMS to hit us on pretty good as far as infection control, and that means cleaning of your stethoscopes, cleaning your blood pressure cuffs, cleaning any equipment you take out, your thermometers, your pulse oxes. If you're taking any equipment in and bringing it back out, how is that being cleaned and disinfected? So make sure you review that policy. Injection practices haven't changed a whole lot, but we've just outlined everything as far as You should be using the engineered needles, the ones that have the safety caps on them. Excuse me. Everybody should have a needle disposal bucket if you're doing anything with needles. One of the big things that I found in one of my other in-services was a lot of people didn't know what the policy was on transporting specimens. So if you obtain a blood specimen from your patient, you have to put it in a clear plastic bag that's labeled biohazard, but you're also supposed to be transporting in a plastic container. So we have coolers that have been purchased and we put a biohazard sticker on it. That is the expectation when you are transporting lab specimens, is that they're in that plastic bag, they're placed into your cooler, and that's how they're transported in your car. I expect them to kind of hit on that because they were very specific in the new regulations that is how specimens are supposed to be transported. So make sure you review that. Make sure you review all of those new proper disposal of infectious waste. And then finally, the bloodborne pathogens and transmission-based precautions. This isn't going to be new to anybody, but we've just revised how it looks to define what contact precautions are, what droplet precautions are, what airborne precautions are, and some of the most common diseases. So contact precautions, the most common ones we see in the community is MRSA and C. diff. Droplet precautions is flu, mumps, and rubella. Those are the most common ones seen. Airborne precautions with pulmonary TB, measles, varicella, and smallpox. Hopefully we're not seeing a whole lot of that out there, but those would be, if you have a patient with any of those diagnoses, we would expect that you are taking in the proper PPE and wearing it appropriately for those patients. The biggest one is your MRSA and C. diff. So, make sure anytime you're going into the home of somebody with either of those that you're wearing your gloves. If you're coming in contact with other things, that you're wearing a gown, slippers on your feet, whatever it may be. But we want to make sure that everybody's protected in the right ways. So if you run across anything that isn't needed in addition to those things, make sure and let your administrator know, and we will supply whatever type of protective equipment that you guys need. Employees will be encouraged and will encourage their patients to receive all recommended vaccinations. We've revised in home health, we are working on revising our patient handbook, and one of those things is going to be to include information on hand hygiene, on cough etiquette, and on immunizations. So the CDC is really pushing hard as far as the rates of immunizations that we're seeing nationwide. In home health alone, I can say that for Springfield, our flu vaccine rate is very low compared to others. Now, does that mean that people aren't getting vaccinated? It could. Or does it mean that we're not recording them correctly? That's more likely the culprit. So make sure that we know the vaccinations of all of your patients. Employees, the only thing that you're required to do is your annual TB screening, but it is recommended that all healthcare workers get the flu vaccine, have their hepatitis B series. If you're at the proper age, getting your pneumonia vaccines. So know that it's nothing that Phoenix requires at this point, but it is still the recommendation of the CDC for all healthcare workers. All right, finally to wrap it up is our QAPI program. CMS gave us very specific components of our QAPI program. It includes the scope of the program, the data involved, the activities, performance improvement projects, and new and improved executive responsibilities. They are really putting a lot of the responsibility on improvement onto the governing body of the agency. So basically, the scope of our QAPI program is to improve the health outcomes of our patients, to prevent rehospitalizations, medical errors, and other adverse events, to improve patient and caregiver satisfaction, and most importantly, ensure patient safety. So all of the activities in performance improvement projects that come to fruition during this program will be achieving or hope to achieve one of those things. The data that we're going to be looking at is our OASIS outcomes, our star ratings, our HCAP surveys, potentially avoidable events, financial and operational data, and our grievances. HCAPS is, the new and rising one that they're taking a little more interest in this year. Obviously, hospice is new, a little bit new to the compare ratings and having those publicly reported. So detailed program and lots of information that goes into it. Some of the activities the agencies will be doing is investigating adverse events and rehospitalizations. CMS identifies adverse events as urinary tract infections, wound infections, falls that lead to hospitalizations or broken bones. I think that's most of them that we look at.
Bruises,
do what?
like bruises and falls and things like that. Okay.
Yep. Incidents and infections are the big ones, along with your rehospitalizations. So further investigation of home health associated infections and incidents. So that's where we talked about the importance of identifying those patients that come on with infections, because we need to be able to identify if they're home health associated. That's where we then try to track it back to a source. And, believe it or not, a lot of times it's fairly simple. Sometimes you can see a repetition of the same staff member, maybe, skipping a step and putting in a catheter. Like I said, there is no disciplinary action associated with all of this reporting. It is truly to come back, find the source, and fix the problem. It's re-education. I mean, it's, talking to that staff member and getting their sterile technique down a little bit better. So CASPER scores and HCAPS analysis will be done, and then investigation and trending of grievances. The administrator is responsible for receiving and investigating all grievances. Our current grievance policy was a little wide. We do have a new one in place with this QAPI program, where it basically kind of differences between what's a complaint and what's a grievance. I think a lot of times, the complaints can be handled immediately. It's, I didn't like the color of Nancy's shirt, or, Nancy said this to me and I didn't like it. Most of those types of things can be handled immediately. The grievance is something that requires a little bit more investigation. Okay, what's really going on here? The complaints usually can be handled out in the field with you guys. Just because somebody isn't happy that you showed up at 10 and they were expecting you at 8 doesn't necessarily mean that we need to write up a full grievance on it, okay? That's a complaint. That's something that can be handled at the time. Now, if the patient isn't satisfied, then we move it up to a grievance. But if it can be handled immediately, some things are just complaints. Grievances need to be handled by your administrator. That requires the documentation, the investigation, putting it into the log. Now, if you tell me that an agency doesn't have grievances, everybody's going to throw a fit at some point or another. So when CMS walks in and they say, we want to see your grievance log, if you don't have something, they're going to know right away that you're just not documenting. Okay, so make sure that if something truly needs to go to that next level, if we were to send a surveyor out with that patient, are they going to be the patient that says, well, I told them I didn't like this? And if it's something that should have been logged as a grievance, we're drowning. So make sure, you can differentiate the two, but know that just because they didn't like the color of your shirt that day doesn't mean we need to log it as a grievance. We need to be able to filter those out. Performance improvement projects is kind of the step where, okay, we've identified this is our problem. These are the obstacles. These are the things that we think led to this poor outcome. What are we going to do to improvements? So performance improvement projects, there's no limit on how many. CMS doesn't say you have to do 4 a year. What they say is you have to do at least 1 a year. Okay, so 1 a year is the basic minimum. Now, if you meet your outcomes before that year, you can't just sit on your thumbs the rest of the time. You have to initiate a new one. But the performance improvement projects will be based on the outcomes and the benchmarks of all the data reviewed, the priority to ensure patient safety and quality of care, the impact on the cost to the agency, and the availability of agency resources. The biggest thing that CMS is pushing is patient safety. So anything related to patient safety, they're expecting to be addressed immediately. So you're going to see some of the performance improvement projects coming out are going to be safety related so that we can knock these out and show that our patients are safe in our care. The process that we go through is to select that outcome, to perform an investigation to try to identify the problems, identify the best practices, develop a plan of action to correct it, implement that, and then monitor it and sustain it. So there's a cycle that we have to go through to show that we do all of these things, especially the monitoring. So there will be some more work when it comes to monitoring of that plan. Executive responsibilities. Like I said, the governing body is being put at the head of all of this. It is the governing body's responsibility to make sure that this is running smoothly. They have to approve the frequency of data collection. They have to approve how often data is analyzed, all the activities and all the projects that are undertaken. In home health, this is the list of the governing body that will be overseeing all of the QAPI programs. So that's Phil, Sandy, and Alex as the vice presidents, Jeff, and myself. Yours is just Phil and Sandy. You're probably going to have to bump that up a little. Yeah. CMS is basically saying your governing body has to show that there's people on that governing body that have a clinical component, that can understand the clinical side, somebody that understands the finances and the financial world, and then somebody that looks at the compliance aspects. So if they can meet all three of those, maybe, yeah. So what is your role in QAPI? All of this is being done kind of behind the scenes by a lot of people. But your role is that you bring forth any recommendations, any safety concerns. Like I said, safety is the #1 priority of CMS right now. So if there's something happening that you feel jeopardizes the safety of the patient or you, we need to be addressing those immediately. So we count on you guys to bring those issues forward. That way we can put plans of action into place to try to fix them. Any recommendations for improvement? And then when it comes time that we're sitting down and we're investigating and we're identifying the problems and the best practices, that's where you guys need to be at the table with us and letting us know, you know, this is the best practice that we've seen, or this is the hindrance that causes this. And then also identifying any fraud or waste. Very important, you guys out there in the field, are we being wasteful with our resources? And then finally, participating in the performance improvement projects, participating in the investigations, the identification of things, and then you guys are usually the ones that are carrying out a lot of the activities that are going on. So it's important that you get a clear understanding of what the goal is for that PIP, how we're monitoring it, what we're looking at, what we're implementing, because you guys are the ones implementing it. So it's important to be at the table when all of these things are being decided. All right, ending with our Phoenix mission. And I just want to say thanks to everybody. I know this is time consuming and there's a lot of new things coming out. But I truly think, you know, as much as I hate to say I agree with CMS on anything, I think they're going in the right direction as far as getting this back to quality care. So hopefully some of these things will help us with that. Emergency preparedness, you know, it's a pain. It's a lot of work. But if it comes down time that we have to activate it, I know we'll all be thankful that we at least have some sort of framework in place to operate off of. Infection control, I think we all do that well to begin with. I don't think there's much of a change in that. other than the official documentation that we have to keep on everything. But other than that, I think everybody practices infection control well. Quality improvement, we all have been kind of teeter-tottering with this. We all try to improve it, but it is time that we really get down to the nitty-gritty and find out what are the causes of some of our poor outcomes. Why are our patient satisfaction surveys down? And a lot of times, guys, it's not anything big. It's they don't know to expect the survey. They don't know how to answer the survey. They don't know what the questions are asking. You know, some of our outcomes, like we talked about, you know, with in home health, we have to admit patients within 48 hours. Well, there's a lot of times that there's reasons we don't. We're just not documenting those reasons. So we take a hit on an outcome that's very important because we just don't have the right knowledge as far as the documentation. So a lot of performance improvement is identifying truly what that barrier is, because it's usually a barrier that's easily removed in order to see improvement. So participate, get involved with all of these. We can't do any of this without the knowledge and what you guys do out in the field. You guys are feet on the ground. You know what's going on with those patients. You know the safety concerns of those patients. You know the safety concerns for yourselves. What as Phoenix do we need to be offering or doing to ensure your safety while you're out there? So please, your administrators have open doors for all of this. Make sure you're taking any recommendations, any concerns, any thoughts on ways to improve this process to them. And I promise we're dedicated to digging in and really trying to make a change and a benefit for not only you guys, but for the patients. So.
I do want to say, I know people who've been here for a while know, but for our newer people, we had a lot of this in place already. It's just beefing it up and adding more detail. And there are some new things, like we'll be having more paper tracking things, which is a good idea. So because, you know, there may come a day, and I hope it doesn't ever happen, where we won't have access to cellular communication. So or we won't have access to where we can pull up everything. I'm a very technological person. I want everything electronic, but it is going to be good to have all these paper copies with us. So Jill and Stephanie and I will be developing that. But just know, I know a lot of you know we have some of this in place. I mean, we had, but just more detail and some additional things too. So, and Emily has put an enormous amount of work into this and has saved, you know, the three of us, our team, from having to do that. And I cannot express how much I appreciate that. And so we will, the three of us will get together and get with Emily and tweak it for hospice. But thank you for all your hard work and taking the time to come and present to us today.
Believe it or not, I love this kind of stuff. So.
You're very gifted at it.
Sandy says I'm just weird. All right. Thanks, guys. Thanks for everybody on the call. If anybody has any questions, please reach out.